My name is Sally Mansour, and I'm the director of the Community Counseling Center with Azusa Pacific. I'm a licensed marriage and family therapist. I've been at APU for 4 years, leading the center. Prior to that, I was in nonprofit mental health pretty much all my career, working primarily with Department of Mental Health contracted outpatient programs and also DCFS programs, leading outpatient community-based, home-based mental health services, family preservations, all of that. It's probably my passion for community-based work and service integration that inspired my initial vision for this day. I take a lot of pride and pleasure in partnering with the University Counseling Center. And with that, I'd also like to introduce my colleague, Dr. Lori Lacy. She is the director of the University Counseling Center. Lori has her master's and doctorate in psychology here from APU. In addition to leading the UCC, she is also passionate about clinical supervision and leadership development, and she oversees the services there. The University Counseling Center is a site for APU students, strictly APU students. And I spend a couple of seconds talking about our services because folks often mix us up. Sometimes I'll run into a faculty and they'll say, oh, I just sent a student to you. And I'll usually say, I think that's probably the UCC. And it's okay, we do serve the CCC, we do serve APU students, but just for those of you who are here, there is a site specific for the APU graduate and undergrad students. I also want to introduce a very important person who is responsible for all of this, and that is Aaron Thomas. He is Aaron is a trainee at the Counseling Center. He's a student in our doctorate in clinical psychology, and he's also the research assistant for working on the SAMHSA grant that we'll be talking about today. We do have folders for you at your tables if you didn't get one, or if you're sitting on the periphery. We do have extra folders with some of our panelists' bios, our agenda, a couple of articles, and information on the community counseling and the University Counseling Center. So we know that APU has a network of resources for students, and that if a student walks into our sites, any of our sites, those of us who are trained in behavioral health will know how to assess them and link them with the right resources, and we know what to do for those of us who are trained. But we often don't speak with each other, or we operate independently sometimes, and it does help to have aligned processes across campus, which is why part of the reason we thought that the grant from the Substance Abuse and Mental Health Services Administration would help tighten and enhance our infrastructure so that we can align our strategies campus-wide. So the objectives for the day, when you leave, we should be able to identify the risk and protective factors associated with suicide and substance abuse, understand and assess APU's protocol for responding to students in distress, and learn about university support and local agency resources. So I'm not going to talk about statistics too much. I think we have a lot of statistics information. We have a stellar group of presenters and panelists for you, several from APU, as well as outside of APU agencies and local providers. But we know that suicide is a leading cause of death for college and university students. We know that substance use and abuse are risk factors associated with suicide. We also know that underrepresented populations are also at risk. So international students, students with disabilities, students of color, veterans, women veterans, the LGBT population. And so we need to become more mindful so that we support everybody on campus, and so that we also don't neglect those who seem to be doing well, but we don't necessarily know what's going on for them personally. So we'll hear a lot about that later. So what we did is we conducted a needs assessment internally. We didn't get that many responses, but 104 responses are better than nothing. We sent out the needs assessment to key student service programs, to all the schools across APU, including our regional campuses. And we received 104 respondents, about 50%, 52% staff, 15% faculty, and 33% students. And the reason we receive student responses, those are student workers, so they're staff, and they received the survey, which is great because we got to hear from the students directly as well. I won't go over every single item, but the primary, in summary, about 50% of respondents stated that they have never received training on suicide or risk prevention, trainings. About 50% of respondents prefer an online and in-person trainings, and about 70% of respondents prefer a protocol sheet as well. We do have protocol sheets for you. We also have a protocol segment of what to do when responding to a student at APU. The two biggest suggestions for improvement were that respondents requested more trainings and also more information on resources, and that most respondents are unaware of resources or don't know where to find them. And I think that last bullet point is so true, because I know, even for me, I know what we do at the CCC. Again, we know what to do if someone walks in and needs support. But if I need to access an APU, campus resource, or if we serve a student who needs help, I'm constantly thinking, okay, who else? Do I need to report this to anybody? Do I need to contact campus safety? Do I call? So usually I'll just pick up the phone or call Lori or contact somebody at the UCC to make sure that I didn't neglect a piece that is required or encouraged here at APU. So we hope to walk you through that process today. So that's where cheat sheets are helpful. So the National Alliance on Mental Illness conducted a national survey of college and university students to hear from students directly about their experiences on campus, and if schools are doing what is needed to support them, to support the student body. And this was a student response that I think it spoke to me, and I think it's so important to be mindful of. So this person said, I think colleges should pay attention to the fact that many more students need mental health services than who actually access them. Some of the students most affected or most at risk for mental health conditions are the hardest to reach because they are secluded in their rooms. And that's so true. Again, I mentioned earlier, even if we don't see it, it doesn't mean it's not happening. We know there's a lot expected of our students. I know even at the CCC, we have students who are working full-time, they're in class full-time, they're doing an internship with us, which is really like a part-time job, and maybe they're married and maybe they have kids. So that's a lot to be carrying on. And so while they may be running around looking like they're the most functional people I've ever met and able to juggle so much, I know there's a lot of stress and life responsibilities that folks are carrying. So you're going to hear a lot about collective responsibility. We have an article for you in your folders. You can take a look at it later. It highlights the importance of coming together as staff and faculty, and not just as behavioral health providers and those of us who are trained in mental health, but really anybody at all level, even the student staff, to support our students, so that it's everybody's responsibility to highlight the importance of keeping students engaged and connected. And the article highlights that autonomy, sense of confidence, and sense of feeling connected are likely, that students who have those traits are less likely to experience suicidal behavior or report suicidal ideations than those who don't have these traits. I think that's huge. And with that, I want to move us into our first presenter, and that is Dr. Nathaniel Fernandez. He is the outreach coordinator at the University Counseling Center, and he's going to spend a few minutes to walk us through responding to students in crisis at APU. So this is like one cheat sheet that we have for you in your folders that I know I have it posted up in front of me because I know we know what to do, but again, it's always easier to speak the same language, especially as we take this information back to our offices and clinics and train everybody else in our offices as well. So with that, Nathaniel.
Thank you very much, and thank you all for your attention. Yeah, I'm here to talk to you all today about sort of our APU-specific procedures for students that are in distress. That's learning outcome 2 that we were just talking about. So I'll be walking you through what's called our 4 Rs. You may have heard several different types of acronyms for responding to students in distress. Here in-house, we're going to use 4 Rs, and that'll help us all stay on the same page. So you can see in your handout folders, there are 2 items that I'll be referencing throughout this. The first one is this colored sheet with the 4 Rs on it. The second one is this red, yellow, green, which I'll get to a little bit later. And also, general information on our counseling center services are here on this small card for you. But yeah, so recognizing, responding to students in distress. We also have this training available on Canvas for you. You should have hopefully gotten an invitation. If you haven't, please reach out to us. But we know, as we were just talking about, some folks prefer in person, which you're getting right now. Some folks prefer online, which is available to you. And you've got cheat sheets in front of you. So hopefully that will help. So first, the steps of our model are to recognize a student in distress, how to find them. Oftentimes you recognize them already and you kind of start at step 2. But we'll talk about that first, briefly talk about responding, which will also be covered later in the training. Then we'll talk about how and when you refer and report these things so that we can make sure that we're all following a unified process and that we're not accidentally siloing any information that could help save a life. Recognizing. Our first step is recognizing a student in distress. There are lots of signs that you may obviously notice right away, right? Students that find themselves bizarre behavior, incoherent speech patterns, maybe uncontrollable emotional displays of frustration, sadness, fear, marked substance use. All of these things you're going to notice for the students that you're working with or that are in your classes or in your scope of care, right? And that's usually when we start to activate some of these protocols, right? The things that we're talking about today, try and use some of these skills. But I also want us, and the reason we start on this recognizing page, is I want to really stress for all of us to notice those more subtle signs of potential distress starting to occur, right? That way we can intervene earlier and we can avoid sort of more catastrophic presentations as much as possible. So things like forgetfulness and difficulty concentrating, things like reports of fatigue and sleeplessness, right? You may start sounding like all college students, but that is because we know a great majority of them are experiencing a lot of stress. So being able to tease out that difference, right? When there are people just saying, oh man, I slept so terribly last night, or oh no, but for real, I haven't slept in weeks, right? And then we know that something's going on. Other things, recent life transitions is one that I always like to highlight, especially because that is a common factor for many of our students, right? Whether they be traditional undergrad students, non-traditional undergrad students, vets, et cetera, right? All students, by coming to university, are changing their lives, right? They're changing their career trajectories. Maybe they're changing their physical location if they're moving closer to commute into a campus. So all of those things are important recent life transitions and why it's important to pay attention to our university students. Also, extreme dependency I like to highlight too, right? You all have some of those students that you're working with that really take a lot of your energy and your resources. And oftentimes that can kind of be fatiguing or frustrating, but I encourage us to try and look at that sometimes as potentially a sign that there may be more going on there, and maybe to ask a little bit more about that and get them referred to the correct resources so that their needs can be better met. So, but once you recognize a student in distress, what are you going to do about it? That's our respond section. So I'll invite you all, I'll start with don'ts and then go to do's. So don't do these following things as much as possible, especially if someone has suicidal thoughts or behaviors. Don't leave them alone at any point until appropriate resources can be contacted, which we'll talk about briefly. Other things, and sometimes these come up and can be frustrating or difficult to handle when you have a very different perspective on a major issue than a student, right? Or that you're working with, or just a person, right? If you have these major differences, sometimes you get drawn into a debate about the morality of certain behaviors or things like that. Maybe that's important things to have that conversation, but when a student is in crisis, they're not going to take in any of that information, and they're going to feel unheard, right? And that can delay their access to service, turn them off, right? And then potentially lead to more harm behaviors in the future. Other things, sometimes we are challenged to challenge students, right? Like we want to say, no, you're not, hopeless. You're not worthless. You have a lot of worth and value, right? That can be important and reassuring in some cases, but also sometimes that can make you feel like you're not listening, right? A student comes off by not being heard in that interaction rather than feeling heard and known and then moving into a place where they can accept that feedback. So we strongly encourage all of you folks not to necessarily push a student forward in a direction, but rather try and meet them where they're at when you're responding. You'll learn a few more tips as we continue to go along. But finally, I want to talk about, and many of you are familiar with confidentiality laws in your various positions, right? But there are certain things that you are going to need to report to the appropriate campus bodies, and certain things that you don't need to, right? And so whenever you are faced with a student who is in crisis and asks you, can you keep a secret for me? Please all respond, I can keep this private for you, but certain things I need to tell somebody about, right? Set up from the beginning the appropriate levels of confidentiality in an area, right? And that will help students not feel betrayed, help them feel understood, and help direct them to the appropriate resources when needed. Resources on campus with a higher level of confidentiality, for instance, our office, the University Counseling Center, and the Campus Pastor's Office, right, operate under a different level of privilege. And so students that really do want a confidential resource can come to us. All right. So I've covered the things you don't do. What should you do? A list of don'ts is only so helpful. So whenever you respond to a student, I strongly encourage you to take the student seriously, to build rapport and take your time, right? And you can do that through body language even. That's our acronym that you see listed here on the side of the screen, SOLAR, but spelled wrong because the E stands for something that doesn't start with A. But basically, whenever you're speaking with a student, you want to communicate that you care by trying to square up your presentation to them, face them head on, open up your body posture as much as you can, try not to look too defensive even if you're stressed out. Lean in to an appropriate level, right? This will communicate that I care and I'm listening to you, like this is weird, right? So, lean into an appropriate level, try and make appropriate eye contact. And most of all, I really want to encourage you is to relax in these situations, right? You've gone through things before, students that you're going with have gone through things before. Even if this is your first time, know that the university has gone through these things before, right? And that you can relax and trust in the web of resources that are around you. So while you are the person responding in the immediate moment to the student in crisis, you are not alone. And that's what we want to hope to instill in the students as well. We talked about the importance of connectedness. So please try and instill hope in students that something can change and things can change for the better. And also always ask purposeful questions, especially our topic today being on suicide prevention. If you think a student is at risk for harming themselves, please ask about this directly. There's a myth that can sometimes put an idea in somebody's head, but we know that that's not true. And rather, if you ask about it, you can get a better idea of where the student is at. And if they are experiencing thoughts such as that, you can help them feel known and understood. So once you've responded to students successfully, our next step as we turn to the back side of that paper is refer. Like I said, please don't feel the need to take on students' care all by yourself. In fact, we would strongly encourage you not to do that, right? There is a web of resources on this campus that we can refer our students in distress to. Folks at the University Counseling Center, folks at the Community Counseling Center. Dr. Bill Fiala is our Dean of Wellness. We have Undergraduate Engagement Service Center, Spiritual Life, Learning Enrichment Center, et cetera, right? All of these different services providing different types of care and making hopefully a network so that nobody slips through the cracks. So once you get somebody referred, We want to go to what the university procedures are for reporting these things. What are the appropriate resources, the appropriate actions to take when you witness a student in an intense crisis or even in less intense crisis? So basically, I want to encourage you to try and match the level of severity with the level of response, right? So clearly, any time that you run into a student at all whose behavior is clearly disturbing or especially imminently dangerous to themselves or to somebody else, that's an immediate call to 911, subsequent call to campus safety. But please respond to emergencies as emergencies and don't get caught up in, where and what and who and how do I do it, APU cares form, et cetera, right? Please call 911 right away in the event of an emergency. But for instance, in that yellow light area, this is where students, oftentimes we have more questions, right? If you're seeing a student, they're clearly in distress, but you're not necessarily sure how serious it is, right? You may or may not be a trained behavioral health professional, or you may or may not have a long-standing relationship with somebody in order to make a risk assessment. We ask you not to do that. That's not what we're asking you to do. But rather, if you are ever concerned or worried about a student, please contact somebody and consult with us. Great resources are available here. We're 24/7 available at the University Counseling Center by phone or during business hours. You can come in and consult with us. We're always happy to talk through concerns and direct you into the appropriate level of response. You can also contact our wonderful Dean of Wellness, Dr. Bill Fiala. And finally, consider submitting an APU cares form, which I'll talk a little bit more about, but it's a form that can really help us fight against siloing of information and really activate a web of care from both academic and co-curricular sides of the university to come around a student and make sure they get the resources that they need to successfully be well and be retained. And then finally, on the green level, if somebody's just going through something, you're pretty sure, they're not risky or anything like that, you don't have questions, but they need something, just please direct them to the resource that they might need. You can always feel free to walk students over to our office. Many staff and faculty members choose to do that if they need counseling, they need somebody to help them kind of get over to us. You can walk them over, we'll be happy to see them. You can also always consider submitting an APU cares form or consulting with us, even if you're pretty sure it's green. We always recommend that you err on the side of caution. So as I mentioned, the APU cares form, you may or may not have seen this before, you may or may not have heard this before, but our APU cares team is that co-curricular and academic team that comes together for students in crisis to make sure they get connected to the right resources. So anytime you're concerned about a student, we ask you to please use this form, the Student in Crisis Notification Form. You can find it there at apu.edu/apucares. And there's information that you can fill out there. You just kind of scroll through and it's pretty self-explanatory. And this can really help us make sure that we're managing our risk as well as caring for students. So anytime that you are confronted with a situation that is a student in crisis that needs to be referred, please use this reporting procedure form. Well, thank you all very much for your attention. I don't know who I'm introducing next, so potentially I will bring Dr. Mansour back up here. Thank you very much.
So we have an incredible group of presenters for you today, and we're going to start with internal APU panelists. And so our first internal panelist is Everette Brooks. He is a U.S. Army veteran. He is the Executive Director of Military and Veterans Services here at APU. He has a bachelor's in business management and an MBA in international business. He has been at APU for 4 years. He's responsible for assessing support structures and advancement of services for the APU, more than 500 military-connected APU students. We do have more detailed panelist bios in your folders, but I just wanted to give each person enough time and credit for all their accomplishments and share that with you here today. Before APU, he was at Cal Poly San Luis Obispo for 11 years, where he led veteran programs and was recognized for his services. Like I said, he has served in the U.S. Army for 12 years, including Supreme Headquarters Allied Powers Europe in Belgium, Camp Pendleton, as well as West Point, New York. Our second, thank you for joining us today. Kaylin Morford is... The accommodations specialist at our Accessibility and Disability Resources Office, which is also formerly known as our Learning Enrichment Center. She is a graduate of APU, graduated in 2017 with her bachelor's in psychology. She is also currently pursuing her master's in child life. As an undergrad, she co-founded Strong, an on-campus support group for students with disabilities, and she partners with faculty and staff on increasing and creating accessibility for our student body. Thank you for joining us. And last but not least, we have Dr. Curtis Lehmann. He is an associate professor in the Department of Psychology in the School of Behavioral and Applied Sciences. Dr. Lehmann has a Ph.D. in clinical psychology, a master's in Christian leadership. He is a certified trainer in QPR, which is a question, persuade, refer model. It's an evidence-based gatekeeper training for suicide prevention. He is also interested in doing a lot of research, and his focus is spirituality and mental health, including post-traumatic stress disorder, stigma, and addiction. Thank you, Dr. Lehmann, for joining us. So I would like to invite Everette Brooks.
Okay, good morning, everyone. How are you today? Okay. I would do a prompt and response call to you, but it looks like everyone's awake. Yeah, my time in the military was really exactly just what you want it to be. It was perfect as far as interacting with the people I had to work with. Some of the stations I was stationed at were just some of the most elite places in the world. So, of course, my view of the military and everything that I stood for and continue to stand for today is very ingrained in my heart. And I have an affinity for everyone who has either gone through or has family members who have gone through the service. So can I get a show of hands of the crowd who has family members, siblings, or anybody in their family that has been in the military? Wow, that's a lot. That's a lot. It's a great deal. So one of the things that kind of bring it home to this topic is that, veterans, as they come into this environment at school, are used to a certain amount of connectivity that allows them to be successful and their family members as they're in the service. So one of the things that I see that's really helpful is that once you become affiliated with a military organization, your counseling level is raised up a bit. As you undergone your experience in the military, you have undergone the appropriate amount of counseling to get you, to kind of help you along the way. At each interval, there's counseling sessions. If you're a leader, you counsel people. If you're subordinate, you get counsel. And that's on a pretty regular basis. And one of the things that I find is that as you continue in your military career, you are a counselor as well. You don't get the certification for it, but I have two gentlemen here at this first table who've been in the military. I think at least we got 50 years of experience between you. Is that correct? Okay, so we have a colonel here who, that means he's been in the military a long time. Successfully been in the military a long time. A lot of counseling in his background. You may not see it in the acronyms behind his name, but that's years of counseling right there that you can refer any military personnel to while you're at APU. This is the APU panel, so I'm going to speak to that. We have another gentleman here who's a senior. The acronyms are a little bit different. Senior Master Sergeant, that's an E9. That's the highest level you can get enlisted. Countless hours of counseling in his repertoire. So the military personnel that you encounter in any touch point has received, they know the concept of counseling. They know how to come forward to get it. They know when they need it. However, the challenge is to get them to articulate the fact that they need that counseling, or they may need something. That's why those signs of recognition just small, subtle things that can enhance your capability to read them and their capability of coming forward. So what I like to do at each interval is build equity with the student. Therefore, when it becomes a situation, you've got enough equity built up in your relationship that they will count on you to say the right thing or do the right thing. I've often had military leaders in my life that I spoke to off duty, and they are willing to help me at times of distress, to help me with my life outside of the military, which in turns help my life within the military. So it's really integrated, the services that are provided to military personnel, veterans, dependents of veterans, because it's integrated. So I have this short vignette I like to, this is a scenario that you could possibly encounter. And by the way, I'll make sure we get everybody's email address. We have a VetNet ally that we teach for faculty and staff. And it's a short series of circumstances and situations that will allow you to either determine in your classroom or in your encounters with veterans certain signs that could get you to understand that there may be a veteran in distress. A lot of the things that happen with mental health and wellness is the fact that a lot of them are invisible, right? So you really have to be in tune when you're building that equity to be able to understand those things. So me, myself, I kind of carry myself in a manner that's, pretty articulate. I do like wearing suits and nice clothes. So all of a sudden, if you see me coming to work with a goatee beard, afro, and just some outlandish clothes, there may be something going on in my life that I need some intervention. I mean, that's just one thing. But as a military leader or as a leader at this institution, we look for those kind of things to help out. Not saying that I didn't undergo a life change and now I'm a surfer. That's not the case, but I would hope that you would ask me how things are going and interact with me to find out, hey, I did undergo a life change and this is me now, So we kind of build up that equity, and we hope when it's time to pull it, like interest in a bank, we want to be able to draw on that and continue to help our military members. So I got a scenario here. Chris is a hard-charging Marine. Last 7 years has been deployed 5 times in support missions, different countries. Each of the 20 years involved in the missions, and Chris is a leader. All he wants to do is make sure that he makes it home and every member of his unit makes it home. The last 2 deployments have been very stressful to him, and many members of the unit have been seriously injured or mortally wounded. So after 20 years, Chris has finally said, you know what, I think that's it. I'm gonna retire and pursue a bachelor's degree in management with an emphasis in leadership. Now, Chris has probably got more leadership experience than the Ph.D. Teaching the class. I guarantee you, and it's real live experience. However, some of that translates to the classroom, some of that does not. So we want to make sure that we're able to assist Chris in his endeavors and get him to identify and articulate his leadership levels so he can finish his degree and then potentially get a job. Transition from military has been difficult enough. Chris applied to and got accepted to APU. He understood his benefits, GI Bill, post 9/11. He gets tuition, a room and board stipend, books paid for. He's got 48 months to do this. So for his duty and honor to his country, now Chris gets a stipend to finish school. So that program is very well. We utilize it here. Currently, we have about 385 veterans or military-connected students who are using their benefits, and then there may be some who have transitioned out of their benefit phase, and now they're paying, or they're trying to get another program to start up so they can continue with their education. So Chris has a lot of units. He's did a lot of things in leadership. He's been encouraged to do his master's degree while he's here. He's got enough money on the books to do that. So Chris is surprised about how good of a student he is. Instructors seem to enjoy Chris in the classroom. He's got a lot to offer. Life's experiences have helped him. He's a better student now than probably he would have been 20 years ago. Everything has worked out fine. He has academic advisors. Everything is good. So lately, Chris has had trouble sleeping and struggles to get to class on time. Embarrassed about his tardiness, Chris elects not to go to class, but will make up the work. He feels like he can make up the work. After a few days of skipping class, the instructor is concerned, reaches out to Chris and warns Chris that if he continues to miss class, his grades will suffer, and he's probably going to have to either withdraw or get removed from the class. With some suggestions from his wife and the family, Chris seeks counseling from the VA and has started to attend therapy sessions to deal with his emotional state and experiences while deployed as a Marine. So now he seeks outside consultation from the VA. That probably involves a little bit of travel to and from locations. It's probably not close by, which involves missing class. So now Chris's scenario has just gotten a little bit trickier. He's faced with the possibility of being referred to a residential program and having to drop out of school, forfeiting the housing allowance that pays a mortgage, or balancing the school and dealing with. He's been diagnosed as PTSD while remaining enrolled. What should Chris do? So here at APU, if a scenario like that happened, we would continue to consult with Chris. We may have gotten a CARES team referral as we've done before, and we act on that, and we try to form a relationship with Chris to make sure that he gets the right amount of help at the right time. We do work with the deans and try to get either a leave of absence where they can return in their good standing to the class once they return, or we get them to understand where they were when they left off, and we can assist with that. So as you see, these veterans, the problem may start out with one thing, but it turns into a multitude of things that we have to be there for and support. And my last point here, I'd just like to say that we do have multiple points of contact for these veterans. We have the care team package. We have myself. We have Colonel Rick Givens here. We've got a lot of entry points that veterans can be identified to, and we can seek out help and assistance. So I'd just like to say that. And please, if you can, the VetNet Ally, we'd love to come to your area and just give you a little bit more in-depth telltale signs on how to help veterans who may be in distress or how to prevent a situation from becoming troublesome, like Chris's case. Okay? Thank you very much.
Hi everyone, my name's Kaylin. I work for Accessibility and Disability Resources, formerly known as Learning Enrichment Center. So I have a few slides I wanted to share with you guys. So I just want to share with you guys the reported disabilities at APU. So it's important to keep in mind these are only what's reported. As we all are aware, there are students on our campus that they may be living with a disability and they don't know that yet, or they've, for whatever reason or another, chosen not to seek out accommodation. So these are reported disabilities, and that includes graduate, professional, undergraduate students, as well as all of our regional campuses. So today I'll be sharing how we can support these students. So we want to get them connected to the accommodations that they need through our office. We want to get them plugged in on campus, and we also want to work to break the stigma revolving around disabilities and mental illnesses. So I just wanted to briefly go over the process of what it looks like to request disability accommodations through the Accessibility and Disability Resources Office. So the first step in the process is that a student will fill out a request for accommodations application The next thing that they'll do is they'll submit sufficient documentation to our office. So from any kind of doctor or mental health professional that knows them well and be able to speak into the symptoms that the student experiences. And then the last step is once we have the application and the documentation, we do an intake meeting with the student. And that's just a space for the student to be able to talk with our staff about what resources maybe they've had in the past that have worked or that haven't worked, how we can make that better for them, and talk about what reasonable accommodations would look like. And then I just have a very long list here of some examples of accommodations that some of our students utilize. Many of our students have comorbid conditions, which means they live with 2 or more disabilities. So some students that live with a chronic illness, such as fibromyalgia, might also experience symptoms of anxiety and depression. So that may affect the different types of accommodations that they have. So it's important to keep in mind the reasoning behind these accommodations are of a direct result of the disability or disabilities or mental or chronic illnesses that the student faces. So as you read through accommodations, it's important to keep in mind that a student who may be dealing with anxiety, they may have a note taker in class because it's harder for them to participate in class and take great notes at the same time. There are students that, they may have been through trauma and are experiencing symptoms of that, and they're having a harder time focusing in class, and so they are recording the class lecture. So when faculty are notified of these accommodations, you won't know the disability that the student faces. That's confidential in our office. A student may choose to share that with you, but it's important as you're reading accommodations to be aware that there are many different symptoms that students face, and that's why we've chosen to offer these reasonable accommodations to students. So a common accommodation for our students that are living with any kind of mental illness is that they'll have an emotional support animal. So the emotional support animal, their only function is to provide passive support to the student. So this is different than a service animal. Emotional support animals are not protected by the ADA, so the student is not supposed to be bringing it to their classes, anything like that. It's to stay in their apartment or their dorm here on campus because APU has a no pet policy. This is a disability accommodation that some students utilize. So the animal is recognized as being a therapeutic resource for students that are facing symptoms of anxiety, depression, anything like that, but they are different than service animals. So we'll talk about service animals next. So service animal, the definition of what a service animal is a dog or a miniature horse, which we don't usually see on campus. But it's a dog that does work or perform tasks for the benefit of an individual with a disability. So those are many types of disabilities. So the dog or the miniature horse is performing work that's not passive. So that's what makes them different from an emotional support animal, is that they're providing tasks. They're trained to do certain tasks for that person's disability. So we have a picture of a dog that's helping a wheelchair user do laundry, but we also have a picture of a service animal that is supporting someone in the military that may be experiencing symptoms of PTSD. So the animal is trained to do physical tasks as well as to notice when their handler is experiencing symptoms of their disability. So students that have a service animal, they are protected by the ADA, but we do ask that they go through our office so that we can notify faculty and staff that there will be an animal in the classroom. And so we can protect that student as well as protect the animal and make sure the animal is safe here on our campus. I always want to share with people, these are the 3 questions that you can ask someone who has an animal on campus, whether that's a dog or a miniature horse or whatever, to see if this is a service animal. Because service animals are protected by the ADA, it's very important that we know what's okay to say and what's okay or what we cannot say. So I have the 3 questions here of what you can ask someone with a dog here on campus. You can ask, is this a service animal required because of a disability? The person would answer, and you can ask, what work or tasks is the animal trained to perform? So you can ask follow-up questions if an ambiguous response is given, but these are the 2 questions that we're able to ask people who may have a service animal. And then before moving on, I just wanted to give a quick shout out to a resource on campus called Strong. So if a student ever were to come to you and disclose any kind of disability, whether that's a mental illness or not, this is a great resource that you can refer students to. It's an on-campus support group for students, and when students are able to be in a support group together and talk about their symptoms and their disabilities, that's a great way that APU has begun to break the stigma against mental illness, is recognizing that it's an issue here on our campus, as it is on every campus, and we have a space for students to be able to encourage and empower each other, as well as to advocate for us having better resources on our campus. And the last thing I wanted to talk about is something that our office is really passionate about in doing disability awareness events here on campus, and would love to partner with your office in doing this as well, is to understand and recognize ableism on our campus and in our community. So ableism is the intentional or unintentional discrimination or oppression of people with disabilities. So this can be obvious, subtle, or unintentional, but it happens every day. And so I just wanted to use a common example that we hear relating to mental illnesses is someone who might say something like, "Sorry, I'm so OCD about this." These are things that we want to be aware of, because in our classrooms, when we're interacting with students, we may never know if there's someone in that room that's struggling with symptoms of living with obsessive compulsive disorder, and saying something like that may, even though you could be a safe person to talk to, a student may perceive that as now you're no longer a safe person to open up to about that. So we'll talk about that for a little bit. Something that our office finds really important is that we function out of the social model of disability, so that we understand that the problem is not the person with the disability. The problem is the barriers facing that person with a disability. So instead of working around the person, we're working around the barriers that society faces with that person. So that's something that our office really focuses on, is strengths-based, and focusing on how we can use that person's strengths to overcome the barriers that face them because of a disability. So we want to ask you guys to help partner with us in combating ableism on our campus, and being aware that it starts with us. It starts with how we speak and we interact and think about disability, how we think about mental illnesses, and it starts with us, and that's how we're able to combat this, is understanding our own thoughts about ableism and recognizing that in our own brains. And the last thing that I just wanted to share about, kind of going along with the statement of what I just said about saying I'm so OCD about this, things to keep in mind is ableist language and how we interact with students or talk in our classrooms, so that students who may be experiencing symptoms of a disability or a mental illness, that we can show them that we're a safe person to talk to, because we're aware of what ableism is and what ableist language sounds like. So it may be something that's totally unintentional, but is always important to be aware. We want to err on the side of just being aware for students and making sure that they feel safe coming and talking with us, so that you can then give them the resources that they need, which may be that they would like to utilize accommodations. But that's everything I have for you guys today. Thank you, guys.
Good morning. Yeah, I'd love to share a little bit about the faith perspective and how that relates to mental health, mental illness, and I've heard a little bit, and I saw the agenda. We're going to hear more about myths of suicide, and so I'm kind of thinking about this as a myth about faith. And how many of you have heard of the concept of the prosperity gospel? Is that something that you guys are familiar with? Many of you, Are many of you aware that idea of a prosperity gospel, the idea that if you are faithful, God will bless you with financial prosperity? Are you aware that that's actually not aligned with Scripture? That's sort of a myth. Okay, so, all right. Just want to make sure we're on the same page. You can cherry pick a few verses that seem to suggest that benefit, wealth can come about from being faithful. I'm not saying that in no case would it ever do that, but certainly the guarantee that financial prosperity comes to people who are faithful goes against actually many of the stories in Scripture. And even Benny Hinn, the famous televangelist, walked back just last week, I saw it in the news, walked back his prosperity gospel, arguing that he knows that he has hurt people when he promised, if you give to our ministry, you'll get 100-fold back. And he acknowledged that he has misled people. And so I give him credit for that. So the prosperity gospel is fading, but I want to talk to you about a different gospel that still has its proponents. And it argues that faith, not that it would lead to financial wealth and prosperity, but actually that it would lead to emotional prosperity. I think that is an idea that is really common in our many of our churches and many of our messages about faith. The idea that faith will guarantee emotional health and freedom from negative emotions. And it's been called many different things, but I like the term the emotional prosperity gospel. Because it aligns it with this other belief that we all, many of us have recognized as being false teaching, as a myth about faith. And I think that this is also a myth about faith that we should be speaking out against and clarifying to our students, because often they've received a different message. So again, in this line of belief, if the presence of depression and anxiety are just incompatible with faith and belief in Christ, that the idea that they could ever coexist is just beyond their belief. In fact, what they would say is that if someone had depression or anxiety and they were a Christian, that they would ask questions that would assume things about their faith, that would assume that they are lacking in their prayer life, that they are lacking in their faith, and not clinging to God as deeply as they should or as they could. And so it often accuses people with mental illness of some sort of shortcoming and failing in their faith as a result of their the signs of depression or anxiety or mental illness that they might be facing. So, and it's present all throughout. Well, not all throughout, but in many Christian ministries. In fact, one Christian best-selling Christian author put it like this. They shared, "It's even possible to live without negative emotions. God will take them off us like a thick blanket if we ask him to. But we have to pray." Now, there are some components of this idea that I don't want to dismiss altogether. For those of you who are Christians in the room, I think that there's certainly the belief that the faithfulness to Christ will, in the long run, lead us to a life of hope and joy and love in Christ. That's the end point that we're all striving towards. That we are, as Revelation says, he will wipe every tear from their eyes, and there will be no more death or sorrow or crying or pain. All these things are gone forever. So it is one thing that I don't want to strip away, which is the hope that one day we will be free of emotional trouble. And there's another part of it that I don't want to disagree with, which is that I actually believe, and the research backs this up, that faith can help with emotional health. That leaning in our faith, there is real benefit that occurs. And we can see that certainly there's some aspects of faith that can be harmful, like believing that God is punishing you or that is abandoning you. But certainly those who lean into God, feel closeness, generally will benefit. But the problem with the emotional prosperity gospel is that it doesn't, and I'm going to go a little theological, it doesn't recognize that the reign of God is, yes, here, but not yet complete, not yet fulfilled. Yes, God has, in Christ, ushered in a new reign, but it's not fully here. I mean, look around us. It's clearly not here. We're living lives that are full of hurt and full of pain and full of sorrow. And so we need to acknowledge that and bring that into our understanding of our faith, that yes, some of us experience some emotional health, and yes, God graciously allows us to experience that, but that's not the guarantee of the gospel. There's no guarantee. In fact, the guarantee in the gospel, in the words of Christ, is in this world you will have trouble. And so that's promised to you. So if you're looking for the promise of Scripture, it is promised. It's a guarantee. I think there's a really appealing message in the emotional prosperity gospel. It's this idea that we can simply lean on our faith, and everything, all the pain will go away. And of course, that's appealing to all of us, right? It appeals to a basic desire, a basic need that we'd like to have. But I hope that we can reassure the students and maybe ourselves, sometimes we need this reassuring, that if you are going through emotional struggle, emotional pain, that is not the result of faith crisis or failing to pray. You can encourage those things, but they're simply the reality of that God's kingdom is not fully here yet, and that God has already let us know that we're not going to have a nice, wonderful life here. I got the 2-minute warning. So what are the implications of the emotional prosperity gospel? Stigma. People feel like they can't talk about mental illness because they think it's a sign, everyone's going to assume that I have weak faith. People won't seek help. They won't want to talk about it because they're so ashamed of what they're experiencing. And even sometimes I think a religious crisis can come about of it, because they start to think, okay, God, I'm giving all I can, but I'm still experiencing this. If your belief is that faith will lead to emotional health, it might lead you to question your faith. So I have a quote, far more poetic than I could put it. It's from Anne Voskamp. She wrote in her book, The Broken Way. The real Jesus turns to our questions of why. Why this sickness? Who is to blame? And he says it like a caress to the aching. You're asking the wrong question. You're looking for someone to blame. There is no such cause-effect here. This happened so the power of God could be seen in him. That's the grace touch of Jesus. The dark is not your fault. The dark is not about blame. The dark is about bravely being a canvas for light, about courageously letting your dark be a canvas for sparks of God's glory, a backdrop for ambers of mercy in the midst of your fire. So I hope in this meeting, this time together, this training, that you could walk away from here and really be a voice to students and to your fellow colleagues and maybe yourself, that your darkness is going to be a canvas for light. If you're faithful, if you work hard to become more fully alive, one day, and unfortunately it's not today for many people, one day though, there is hope and joy and love that will arrive in full. And so thanks for letting me share.
So our next piece is a group of also excellent presenters from the community. We're starting with Dr. John Smith. He is the Director of Education and Training at Social Model Recovery Systems Incorporated. He is a licensed clinical social worker, a professor of addiction counseling at Mount San Antonio College. He's been there for a long time. Private practice, specializing in treating co-occurring disorders and trauma. He is the author of Co-Occurring Substance Abuse and Mental Disorders, a Practitioner's Guide. He's the best-selling author of The Authentic Man, A Guide to Happiness and Purpose. Welcome and thank you for joining us today. Our second presenter is Christopher Abernathy, the Senior Director of Treatment Services, also with Social Model Recovery Systems. He has a Bachelor's in Human Services, a Master's in Psychology and Behavioral Health, and is currently completing his Master's in Industrial and Organizational Psychology. He has been in the human services field for over 10 years and also at Social Model Recovery System since 2009. He has carried the role of peer counselor, program director, regional director prior to his current role as Senior Director of Treatment Services. He is the co-chair of the Service Area 3 Advisory Council meetings with the Department of Mental Health. Welcome and thank you, Christopher. Our third speaker is Patricia Speelman from Didi Hirsch. She is the Division Director of Suicide Prevention Center there. She's been in the industry for 25 years, has a Master's in Psychology, is a licensed marriage and family therapist. Previously, she was the director of a partial hospitalization outpatient program in a psychiatric program for a 200-bed hospital in Long Beach, where she chaired their suicide assessment risk team and developed protocols, policies, and procedures and trainings. She does presentations and trainings nationally and internationally on suicide prevention. Welcome. Thank you for joining us. Thank you all for taking the time out of your busy schedules. Last but not least is Tracie Andrews, a licensed clinical social worker. She is the mental health clinical supervisor on prevention, the Prevention Services Administration with the Los Angeles County Department of Mental Health. She has worked in a variety of settings and has extensive experience working with disenfranchised communities. She is the lead for anti-stigma, suicide prevention, and health neighborhoods with the county, and she's currently serving as co-facilitator for the LA County Suicide Prevention Network. I still plan to attend those meetings. So welcome, everybody, and thank you for joining us today. So let's start with Dr. Smith.
Good morning, or actually almost good afternoon, everyone. I'm Dr. John Smith. At least that's the name they gave me in the witness protection program, so I've kind of stuck with it along the way. Honored to be able to talk to you today, especially about this topic. I have worked in the mental health and substance abuse field for a long time, and this particular area always seems to be of importance. And what we're talking about today is suicide, suicide awareness, suicide prevention, but what's the link between suicide and substance use? Well, a lot, all right? So I'm gonna cover some stuff that I have, and I'm not going to go through all of it because I think my distinguished colleagues are going to cover some of the same stuff in terms of statistics, but let me relate it right off the bat to substance use. The new term, by the way, is substance use disorder. So we're no longer calling it substance abuse, we're no longer calling it substance dependence, so you're going to hear people calling it substance use disorder, and it can be mild, moderate, or severe. So the ones that we're most concerned about are those that are progressing. They're moderately or severely in the middle of a substance use disorder. They can have more than one. It can be an alcohol use disorder. It can be a cannabis use disorder. It can be an opiate use disorder, and in many cases they have more than one. The strongest predictor of suicide is alcohol use disorder. Well, what's that mean? It means those two go hand in hand. Alcohol is not necessarily the cause of suicide. Alcohol is on board in most cases of suicide because alcohol is a disinhibitor and it actually allows people to move in the direction, do things impulsively, do things without thinking, a shot of courage, if you will. And so alcohol is on board in most cases of suicide. Opiates are coming in with a strong second. Opiates being either prescription opiates through illicit opiates like heroin. People with substance use disorders are 10 to 14 times more likely to commit suicide than the general population. So when you mix one with the other, we increase the possibility and the amount of suicide risk quite significantly. Alcohol and drug use may be an attempt to self-medicate symptoms of depression or other mental disorders. So while not all depressed people are suicidal, most people that commit suicide are depressed. So when we have one, we have the other. Now here's where I really want to emphasize, because your particular population, young adults, 18 to mid-20s, are in a group of people that are extremely at high risk for suicide. That particular age group has one of the highest rates of suicide. In fact, it's probably the second leading cause of death in that particular category. Might even be first if we look at all the variables. When someone who has both a substance use disorder and a mental disorder, what's a mental disorder? We talked about some of them. The most prominent one, depression. Second would be some related anxiety disorder. Post-traumatic stress disorder is included in that category. Psychotic disorders, which most of you are familiar with the term of schizophrenia. Bipolar disorder, which is a mood disorder characterized by mood swings from severe depression to mania. Why do I bring all this up? Because the age of onset for those major mental disorders happens to be late teens to mid-20s. So the good news is if you've reached 40 and you haven't developed one, you're in probably good shape, all right? But that's the age of onset. That's also when adolescents and young adults start experimenting and using alcohol and other drugs. Again, sometimes a mental disorder comes first, sometimes a substance use disorder comes first, but very often they come together, especially at that age, because sometimes people are using to self-medicate symptoms, or they're using and it causes symptoms, and now they have more than one disorder. I'm sure you see that all the time in your counseling centers and with your students. So I'm bringing this up because this is really what we're looking at. How do you spot one versus the other? And you're going to see it. You're going to see changes in appearance, changes in behavior. We don't know what's causing it, but when you see sudden changes in behavior or appearance, then you know something's going on. So let the experts decide specifically what's going on. Your job is to say, hey, there's a student, something's weird about them, something's going on, something's changing, I'm really concerned, and I initiate a referral. So there are some interesting things that you may want to know about drugs that you don't necessarily know. I'm going to let my colleague Chris Abernathy talk to you a little bit about some specific things going on with certain drugs that you may not be aware of and that I think are important, because certainly your students are aware that there are things going on with drugs that you may not know. In fact, real quickly, I just wanted to say I heard on the radio this morning that I think it was 4 or 5 people died over the weekend of a fentanyl overdose. Well, fentanyl is a synthetic opiate. It's now being manufactured cheaply in China, shipped to South America, Mexico, being put in other substances, and so it's coming in as Xanax. It's coming in as Vicodin or other opiates. It's coming in even mixed in methamphetamine. It's coming in mixed in other substances, and it's about 100 times stronger than heroin. So people are putting it in their bodies thinking it's one thing. They're dead because they take too much, but they don't even know they're taking it, and it kills them almost immediately. And it's very difficult to revive them when they're overdosing on fentanyl because it's so strong. I'm going to let Chris kind of talk to you a little bit about opiates and other drugs, and I appreciate your time. When there's questions, which I'm sure there will be, I'll come back up.
So, hi, I'm Chris Abernathy. I'm a sober guy. I've been sober about 12 years. Alcohol and prescription medication, primarily Xanax was my choice of substances. Both are very deadly combination together, but started in the field about 10 years ago, so I was a couple years sober when I started. So I want to talk about marijuana use first. When our new Surgeon General was announced, it wasn't really big in the press. But Jerome Adams, he's really big on talking about marijuana use lately. He made a quote that this isn't your mother's marijuana anymore. The THC level in marijuana is about 75% stronger from back in the day when 60s and 70s were around and marijuana use was just as big as most of the other substances. But we're seeing a lot of psychosis in our adolescent programs where the psychotic break period is 18 to 25. We're seeing it mostly 12 to 17-year-olds. And it's a tough drug to convince the adolescents and some of the adults now, because you can't really put them in the spot to where you're letting them know that they're going to experience this psychosis the rest of their life if they don't stop using these drugs, especially marijuana, with the THC level where it is. Some of the things we've done as an agency is we've created MAT champions, so medication-assisted treatment are medications along with counseling that help people battle addiction. You guys are familiar with Narcan? So I also carry an overdose kit with me, and I can provide some trainings for folks that want overdose kits. We can make some time to do some trainings, but with the recent opioid epidemic, we've created a conference with our agency. This will be our second annual conference in November, where we're going to have some speakers out there to talk about some of the things that are going on. With suicide attempts and successful suicides, we've experienced a couple in the history that I've been with the agency. One followed right after Robin Williams took his life, and this person had done it the same way. It was a friend of ours that, it's very sad to hear these things. But I know some others of you will talk about the signs and symptoms, but the substance use is major here, because it's what's happening with substances out there now, especially with the opioids and the fentanyl. It's a surprise for most people that there's fentanyl in a lot of these other drugs. Yes, there are accidental suicides, but there's also a lot of fentanyl being found out there. Orange County doubled their fentanyl busts in the last couple of years. This last year, they found 44 pounds of fentanyl. Some of the warning signs. This relates to suicide and substance use disorders, and I know someone talked about the behaviors that people show as they're using substances. Hygiene goes, school grades, family interaction, but isolating or withdrawing from friends or social activities, expressing a desire for death or talking about suicide, acting agitated or anxious, reckless behavior, giving away prized possessions. And sometimes when we've experienced this in some of our programs, it hasn't happened often, but a lot of the time our staff aren't trained well enough. One of the things that we did is we brought Dr. Smith to our agency to help us do a better job with training our agency and the community. We've really done a poor job in the past with doing some trainings with the agency, and now we're helping out a lot of folks where we can educate them. Heavy alcohol or drug use, I can say firsthand, a lot of folks, when they come to us, the primary diagnosis is depression and anxiety. In our substance use programs, we're having to prove medical necessity through the ASAM criteria, but we're seeing a lot more people at the 3.5 level of care, which has that mental health component to it. So I've always had a love for the Los Angeles Department of Mental Health, because it's all coming back around to when I was a peer counselor, to where we're seeing a lot more mental health diagnosis on board because of a lot of the substance use disorders. Marijuana primarily. But this opioid epidemic, guys, is very serious, and you're going to hear stuff all the time about what's going on out there. I know in San Francisco, they're finding less needles in the metro system. People are just smoking fentanyl now. So, and don't forget about carfentanil. Carfentanil is even stronger than fentanyl. A grain-sized piece of carfentanil can kill you. Find some folks that can educate you. I can come out and do some trainings, some Narcan trainings. We can get some staff together to come out and do some trainings related to substance use disorders and mental health diagnoses. Again, heavy alcohol or drug use, depression or other mental health disorders. Sometimes the first diagnosis when a psychiatrist comes to our programs may be a misdiagnosis because of the recent substance use disorders. A lot of the adolescents we see, these are behavioral health issues related to substance use, short-term substance use disorders. And diagnoses change. We have a lot of staff that want to change the psychiatrist diagnoses, and typically if they're licensed, they can do that. So we're still learning a lot. So now there's a new wave coming across we're having to find ways to treat folks with, and again, opioids, the marijuana with the THC levels, and trying to reach out to, there's not much really in prevention, dollars-wise, so prevention and early intervention is strong, and we need to provide that for folks. And hopefully before they get to the college level, grade school and middle school is prevention, and high school is treatment if we don't take care of it in the early onset. They say the opposite of addiction is recovery. It's social connectedness is the opposite of addiction. So social support, we'd always have to put that in our notes. When I started as a peer counselor, we always had to mention social support in our notes because we don't stay sober alone. And we can't take care of the mental health disorder unless the substance use disorder is taken care of. So there's a lot of contraindications and things that happen with psychotropic medications and substances, even some natural things and energy drinks and caffeine. And some of our folks go to AA meetings, and some of the old timers tell them, you're using psychotropic medications, you're not sober, it's a mind-altering substance. And that kind of discourages some of these guys, and gals. That's not how it works. I've been going to AA meetings for a long time, and that's caffeine and nicotine is a mind-altering substance, and they're out, smoking and drinking during the meeting. So, what can you do? Well, there's NAMI is big out there. NAMI has a couple things. They have a helpline. If you guys want to write this down, 1-800-950-NAMI. That's NAMI. And they also have a crisis text line that's really a great resource. So you can text the word NAMI to 741-741. This is something you can hand off to folks when they're in crisis. If you haven't been trained and you don't know about naloxone or Narcan, please reach out to me. We have a couple other resources where we can get some training and it's not illegal to carry it. Good Samaritan law applies as well. So. Sure. So Narcan is an opioid antagonist. So when somebody is in overdose, they're either unconscious or they're what appears to be snoring. Their heart rate and their breathing subsides to a level to where they just stop breathing or the heart stops. So when you administer this nasal Narcan, it sits on that receptor in their brain and it blocks all the opiates from doing more damage. But the most important thing is you call 911 right when it's administered, because in about 45 minutes after you administer Narcan, they'll go right back into overdose. So that's the most important part. With medication-assisted treatment, we offer Vivitrol, which is an injection that you can get for alcohol use disorder and opioid use disorder that will stay in your body for 30 days. And if you drink on it or you use on it, you're not going to feel the effects of the drug. Is there overdose potential for opioids with Vivitrol? I believe so, if there's enough. But become educated also in medication-assisted treatment. MAT, you hear about it on the radio quite often. but it's a combination of medications and counseling that help people. You know, it's almost like antabuse. I tried antabuse when I was back drinking, and I drank while I was taking antabuse. You know, you could still feel the drunk, but still get sick. Drug addicts and alcoholics become chemists, really, and they know how to balance out the methamphetamine with the opioids and the alcohol with the methamphetamine. And now, as Dr. Smith mentioned, there's drug dealers out there that are putting fentanyl in other drugs and cutting fentanyl into, you know, what appears to be Xanax, or there's even a group of folks that go out to concerts and test people's drugs that they have just to make sure they're not taking something that it's not, without the person getting in trouble. So, again, Narcan, naloxone, I have quite a lot of it, and I could do some trainings. So if you guys need my help, my business cards are out at the social model table. And I believe that's all I have.
Good morning, everyone, and thank you very much for inviting me to be part of this symposium. So I'm just going to cover a little bit about the risk factors and buffers or protective factors involved with suicide. But first, I have just a couple of what we used to call myths. At Didi Hirsch now, we're just calling them inconsistencies, or what's true and what's false. And I don't have the slide on here because we're going to have Tracie talk about that in a little more depth. But true or false, I have a couple questions for you. Do you think asking someone if they're thinking about suicide will increase the likelihood of them acting on those thoughts? How many people think that's true? Oh, very good. How many people think that's false? Very good. This very educated group here. It is false. People who talk about suicide just want attention or are not serious about really doing it. How many people think that's true? Okay, again, good crowd. How many people think that's false? Right. Although there are people, though, who are kind of crying out for help or are seeking attention, and that's because their situation has become so desperate that they're saying, look at me, look at how desperate my situation has become, that this is the only solution that I can think of to end my pain. You know, there are many reasons that people may consider suicide, and usually most of them don't want to end their life, but they want to end the pain that they're in, whether that's mental, physical, emotional, spiritual, psychic pain. They're wanting to find an end to that, but they may not actually want to kill themselves and die. So how many of you think suicide is preventable? True or false? True? Yes, most suicides are preventable. Some use to suicide statistics. This is a very critical unmet need, as a couple of our previous presenters have mentioned. The suicide rate for youth ages 10 to 14 has doubled since 2007, 2 times in the last 12 years. It's the second leading cause of death for anyone age 15 to 24, so teens to young adults. And that's a significant statistic. You know, the overall rate of suicide is 10th in the US, but for this age group, it's the second leading cause of their death. The only thing that causes more deaths are accidental deaths, whether those are car accidents, sports injuries, accidental poisonings, what have you. And also something that's very incredible to believe, but children in grades 9 through 12, 1.1 million of them have attempted suicide in the past year. Millions of people think about suicide in the US. 1.23 million actually make an attempt, and out of those, 47,000 will die by suicide. So what are some of the risk factors? Well, increased capability is one. The behaviors and characteristics, and many people have already talked about this, but things like behaviors like all of a sudden there's substance use, right? They never drink, they never smoke, now all of a sudden you'll see drinking, smoking, using drugs. Risk-taking behaviors, those high-risk behaviors, they're starting to drive fast. They're doing those kind of extreme sports, having unprotected sex. And then also you'll notice like difficulty with sleeping, maybe too much, too little. All of a sudden they're eating, they're gaining weight, or they're losing weight. We also have precipitating factors. any recent crisis, something that pushes someone into a state of crisis. It used to be, the statistics were until the CDC came out with a report last year in 2018, that we said that 80 to 90% of all suicides were somebody who had a diagnosed or undiagnosed mental illness. That's not so much the case anymore. The CDC is telling us that about 50% of the suicides that have occurred since the Surgeon General's call to action in 1999, until that report came out last year, are due to psychosocial stressors, a recent loss, a loss of a job, a loss of a relationship, a loss of home, many different psychosocial factors. Legal problems, substance use problems cause a lot of legal and financial issues. And also family history. Is there any family history of suicide? We know that there are generations of families that have suicide run throughout their lives. You want to pay attention to that. Have they made any prior attempts? Have they talked about suicide before? That puts people at risk. And it doesn't necessarily have to be somebody in the family that's died by suicide. We just mentioned suicide contagion. It could be anybody that's close to that person that they've known in some capacity. Risk factors with teens. You want to look for disruptive behaviors. Again, that loss, the relationship loss, a breakup with a boyfriend, girlfriend, significant other. It's very impactful when this may be your first, a relationship that you have in your life that has some meaning to you outside of your family relationships, when that's gone. Are they a victim or a perpetrator of bullying? Back in my day, I'm much older than many of you here, if anybody bothered you at school, if there was a bully in the neighborhood or at school, you could go home and you can disengage from that, right? The only way they could get a hold of you is that they had to call those landlines. And usually your parent answered the phone. If you didn't want to talk to anybody, or your parent didn't want to talk to anybody, that was the end of it, right? They just hung up. Our teens, our youth can't get away from that nowadays because they are connected socially 24/7 through cell phones and social media. And then if there's any abuse, could be physical abuse, mental abuse, sexual abuse, that's also a precipitating factor. And lastly, again, the suicide of a peer, somebody that they've known, or delinquency. And this doesn't just mean that they're delinquent from school. That's one of those behaviors if somebody starts missing classes you want to pay attention to. But any types of delinquency, again, those behaviors where they're maybe starting to be angry, or they're stealing things, or they're taking things, or any other type of negative behaviors. And self-injury. This is very, very important. For some people, self-injurious behavior is a coping skill. It's not a very effective one, but for them it works. We hear that all the time, that when I get really anxious, or I'm really, really stressed, or I'm starting to think about killing myself, I'll cut or I'll burn, and that tension is relieved. It's a very high-risk behavior, and you want to keep an eye out for that. And what we want to do is we want to give them other means of more effective ways to cope, but not negate that, because it's something that you may have to deal with. Signs of self-injury are frequent or unexplained bruises, scars, cuts, or burns, any consistent inappropriate use of clothing to conceal those wounds. If you see somebody obviously wearing really long sleeve shirts and it's the middle of the summer, right? Or they're wearing baggier clothes, or all of a sudden you notice that they're not dressing the way they used to. It may be because they're trying to conceal some of these injuries. And also spending an unusual amount of time in the bathroom or isolated areas. They're going off by themselves, and I don't think anybody that I've ever known in my years of practice ever doing this in front of someone else. It's always a very secretive behavior. Okay, so what are some of the warning signs and invitations? In suicides, 4 out of 5 suicides, 80% of the time, warning signs and or invitations were present. So what's the difference between a warning sign and an invitation? A warning sign are signals of dangers, things like cutting, those high-risk behaviors. Invitations are things that encourage us to respond. Somebody saying, I feel disconnected. I don't feel like I belong to any situation, any group, any class or anything like that anymore. I feel like I'm a burden to my family. The appearance is, again, the changes. Somebody who was always very well dressed, clean shaven, now all of a sudden they're sloppily dressed, their clothes aren't clean anymore, they're disheveled. Everette mentioned all of a sudden you're wearing different types of clothing, or you've gotten your fro, and you want to pay attention to that. Some of this stuff is what we would consider kind of normal developmental behavior. You know, people are searching for their identity at this age, but you have to kind of assess, is this part of that transition from being, you know, a dependent young adult or teen to an independent adult going out into society to make their way. Statements. People will often, and again, most of the time, 80% or so, we have people talking about wanting to die or kill themselves, talking about feeling hopeless or not having any reasons to live, talking about feeling trapped or they're in some kind of unbearable pain, talking about being a burden to others, and also showing rage and talking about seeking revenge. Sometimes people will kill themselves to get back at somebody else. Sometimes people will kill someone else before they kill themselves. So you also want to assess for that and be aware of that. And then feelings and affect. Again, you know, if they're depressed, if they're agitated, if they're anxious, if they're having expansiveness, or all of a sudden they appear to be manic, or some dysthymia. Somebody who was happy-go-lucky all of a sudden is kind of sullen and moody. And not to keep belaboring this, but behaviors, as we've talked about. And then writings and drawings and social media. A lot of people are very expressive, and they will write things, they'll journal, or they'll draw photos, draw pictures. You want to, if you have an ability to do so, to investigate that as well. And social media, it's the way that youth talk to each other nowadays. I have a 19-year-old, he's 20 now, nephew who's attending university. I don't think he ever uses the phone to dial somebody and call. Everything's text, everything's Snapchat, right? Everything's FaceTime. So there's an example of a 12-year-old who reached out to our crisis line because a 13-year-old friend of hers posted something on social media about wanting to die. So she called the crisis line going, what do I do? How do I help this person? We also have a 19-year-old that came in for treatment who sent out a text to a lot of her family and friends that said it's been real. And they got very, very concerned, and thank goodness they got her help. So we've talked about contagion. Is it real? Yes, suicide contagion is real. It's the existence of a causal effect from suicidal peers, and it's contentious. And this is from Thomas Joyner. If you don't know him, he's a professor at the Florida State University, one of the leaders in suicidology. Has written a lot of great articles. The effect of contagion seems most likely to appear in adolescent populations for various reasons, some we're not clear about. But there are multiple documented suicide deaths that have occurred in short periods of time in teen social groups. Palo Alto, in Palo Alto there was suicide contagion where several teens died. Also in Colorado Springs, it's happened throughout the U.S. Public discussion of a death by suicide needs to be fact-based, and people need to avoid sensationalizing it. We want to make sure that we're not putting out these memorials to the person who died. You want to avoid memorials that glorify or idealize the person, because again, when you're glorifying that and you're over-idealizing somebody, what message is that sending? And you also want to avoid discussion of the method of death or showing graphic depictions. You also want to be sure that you're helping those people who have been impacted by the suicide, hold on-campus debriefing sessions, provide counseling and debriefing resources. Risk assessment, I'm just going to touch on this briefly. These are the 4 principal risk components of suicide, and this is Dr. Thomas Joyner's model. So things that have to be present for suicide to happen. There has to be the desire or the want to kill yourself. The person has to have that desire. They also have to have the capability, which is the means. And that's one of the things that concerns us when somebody says they're cutting, right? Because that cutting could get to be where it's actually lethal. There's the intent. You have to have the plan to kill yourself, meaning I have the desire, I have the capability or the means, and now I really want to do it. I plan on doing it in this period of time. And then buffers and protective factors. This is the one thing that, given the other three, can lessen the person's risk. And that's the safety components that can be put in place to help a person who is having the other three parts. So what are those buffers and protective factors? There are things like, for a child or an adult, it can be the parent. We've had a lot of people who say, I'm not going to do anything while my mom is still alive, or my parents are still alive, because this would kill them. We really have statements like that. For a parent, it can be that they're going to live for their children, but once my children graduate, once the youngest is out of the house, they don't have that reason for living anymore. Pets, believe it or not, for a lot of people who are single or who have, an empty nest, having a pet, well, there's nobody here to take care of my dog after I'm gone. So my dog is helping me stay alive. Best friends, some people have that connectedness. They have that social support. They wouldn't want to hurt their friends and family. And then also, again, those special events, those anniversaries, they're not going to kill themselves before this person graduates from whether it's high school or college. They have a big trip that's coming up, or somebody's got a significant birthday or an anniversary of some sort. So things that you want to ask is, do you have any supportive people in your life? When you've had this situation happen before, who were you able to turn to? And was that person effective? Did they help you? Were they a support? Does anyone know that you're thinking of killing yourself? A lot of people do put it out there in subtle ways sometimes and in not so subtle ways, but people also need to know that they can talk to someone. Do you believe you have a sense of purpose in life? Having something to look forward to, having something that gives you some meaning. And then on a scale of 1 to 5, we at the Suicide Prevention Center ask them, 1 being not very connected or unconnected, and 5 being very connected. How connected to others, how supported do you feel? Okay.
So one of the things I just wanted to actually say, because you were asking about social media, we actually had 2 of the developers come from Colorado that did the study, that were studying the contagion effects, and one of the kids that participated in the event, this is a quote, said, "There's a lot of space between kids and adults." Meaning, they want parents to be involved. And we have to do a better job as adults and people that care to ask questions and to be nosy in a loving way, but to be connected. Essentially, that's what this is about. Suicide prevention is really about connection. It's really about connection. It's and you don't have to say the perfect things. You just have to show that you care. So if you ever in that moment and you're like, oh God, please don't say the word, please don't say the word, please don't say that, please don't say that. I'm not trained, I'm not a professional, I don't know how to do this. It's okay, you don't have to be. All you have to do is be somebody that cares. And if you're not fully trained in that capacity, get them to that next person. That's what it's really about. You don't have to be a professional. If you get anything out of what I'm saying, because really, honestly, everybody took all my slides. I was like, really? Really? So this is a test for y'all to see, make sure you paid attention, because I'm going to ask you. But you don't have to be perfect. And like Patricia, who took my very last line, I just want you guys to all pull out your phones real quick, if you have not done so, and I want you to put in 1-800 273 8255. Okay, that's the National Lifeline number. I want you to know you don't have to call if you're at the point of wanting to die by suicide. So it is the national number, it's the national hotline number, but it doesn't have to be the last resort. If you're starting to have ideations, or if you know somebody that's just kind of having ideations or just kind of talking about it and just doesn't seem right, you and your friend can call together. It doesn't have to be the last line. Does that make sense? You can give that number to anybody that you know. You can call anytime that you want, 24 hours a day, 7 days a week. Okay, so let's see how well you paid attention, because everybody took my slides. True or false? Nationally and in California, there are more suicides annually than homicides. True or false? That's right. It's the 10th leading cause. Thank you. Right. Yeah. One of the things I did want to point out, though, is for women who have had babies, after the six-month mark to 12-month mark is actually the most dangerous time for suicidal ideations. So if you know somebody that's just given birth, that 6 to 12-month period is the highest rate of suicidal ideations. Okay? As far as substance abuse, somebody that has died by suicide, 50 to 60% of those cases, alcohol or drug abuse has been present. True or false? Most suicides happen without warning. Thanks, Patricia. Yeah, okay, guys. But I appreciate you going along with me. Thank you. So yes, most people do give some type of warning sign. So they say 7 out of 10, and then 4 out of 5 teens typically display some type of behavior or statement that would give some type of indication. Again, you don't have to be this clinical person to say, oh, the way that they said that word, that seemed off. It's not about that. It's just little subtleties that you notice your friend just not seeming quite right. And just asking that question, hey, are you okay? And never say, you're not suicidal, right? Because in that question, and I've heard a lot of professional people actually say that to clients, you're not feeling suicidal, are you? No, not at all. Especially not right now, because you just said that. So making sure that your invitation to speaking is open and non-judgmental. If someone truly wants to kill themselves, they will eventually complete suicide. True or false? False. Most people who are suicidal don't want to die. So there's this period of ambivalence. And so one of the things that's the most important thing is if you know somebody that is suicidal, the biggest factor that you want to do is create time. If you can create a gap in time and give them something else and give them support, typically some of those suicidal ideations and behaviors will subside. Now, there's about a 10% population that even if they're feeling suicidal will go on to die by suicide, but for most people, it's that gap in time. If you can give that space and time, it can really make a big difference. Teens have the highest rate of suicide. This is for all ages. Teens have the highest rate. So true over here and false over here. Okay, so whoever wins buys lunch. I saw 5 guys when I was coming in. I was like, oh, I'm going there. It's false. It's actually older adults, older white men actually have the highest rate of completed suicides. So one of the things that Patricia did talk about is that the teens are actually, the death rate is rising, and in California, but in Los Angeles County, Latina teens actually are having the highest rate of suicides, followed by African American boys. We're seeing a higher rate of completed suicides. The other disenfranchised group of kids that we're seeing are LGBT+. Now, this is kind of a pet peeve of mine. I just want to make it very clear that they are not at higher risk because they identify as gay, lesbian, bisexual, or plus, okay? It's not because they identify. It's because of the bullying. It's because of the rejection. It's because of the isolation. It's because of pure relationships. So please don't think, oh, because you're LGBT+, you identify that way, that means you're at suicidal risk. That's not what that means. You just have to take in all factors, okay? So when you hear data and statistics, make sure you kind of ask additional questions. Females are more likely to be suicidal. True or false? Females are more likely to be suicidal, but men are more likely to have completed suicides. True or false? Improvement following a suicide attempt or crisis means that the crisis is over. It's false. For most suicides that occur within days or weeks, there is an improvement, but there's also an increase in energy. Okay, so for a lot of people, they think, oh, I've been depressed, and so now I'm feeling better. And so people, when they hear, like, I'm feeling better, people are like, okay, that's great. But most people don't die by suicide when they're feeling the most depressed because they just don't have the energy to do it. And so it's when you start to come up and start to feel a little bit better, actually, that the risk factors are more pronounced. So from data, what they say is after your attempt, 2 minutes, thanks. What they say in data is after your first attempt, it's usually between 6 and 12 months, or actually a heightened period of time. But there is no single cause, and really anybody can die by suicide at any time. This is just what we've seen in data. Suicide is most frequent around Christmas time. True or false? You are adamant. I love it. Okay, true. Anybody disagree? No? All right, guys. The highest rate that they found statistically is actually in April and spring. So we're just going to end on this. One of the things I just want to keep bringing back together is you don't have to be an expert. One of the things that we do is, so I work for the Department of Mental Health. I'm very fortunate in my position. I am the lead for suicide prevention for Los Angeles County. 2 of my staff are here from the Partners in Prevention of Suicide. For suicide training, they do trainings, we do events, we do a lot of different things. They're wonderful. But we also have this other subsection called the Los Angeles County Suicide Prevention Network. And what we're really doing, and it's for all of LA County, and it's a public-private partnership. And so my co-chair is Cheryl Eskins from Teen Line. And one of the things that we get to do is kind of get outside of the box of just DMH and bureaucracy. So we get to do things like have a logo and have swag, and so, which is really important. And so what our motto and our logo is the hero in each of us, and you'll see it on our tablecloth. It's the hero in each of us. Everybody plays a role in suicide prevention, okay? You don't have to be an expert. You don't. You don't have to be like, I just don't know. If you're kind and compassionate and caring, that is literally enough. So one of the things I just want to end on, I love Brené Brown. Anybody else love Brené Brown? I love Brené Brown. Put your time down. We're going to finish this. Speaking of kind and compassion, we're going to do this, okay? But we show this a lot in our trainings, and it's just a reminder of how important it is just to be kind and compassionate.
Well, thank you, Tracie, and thank you, everybody, for being here today. The sheer fact that you guys are here tells me you are passionate about student mental health. So I love each and every one of you in this room, and I'm so excited that you came today. As we wrap up today, I want to give us some basic tools of what do we do. We got a lot of great information today about our students, some of the challenges they face systemically, culturally, in research, but what do we do? And when we're on the front lines, as many of you are, as you sit with students in an academic advising or study away discussion, as you sit with a veteran, as you're a chaplain, as you navigate your engagements with students, what do we do when we see that they're distressed, and how do we best care for them? We want to teach you guys a basic tool, feel, felt, found. We find that 1 in 4 students as they go throughout their career at a university setting deals with some sort of mental health concern. So if you think of the 4 students that you come in contact with on a daily basis, the statistics are that likely maybe 1 of those 4 deals with anxiety, depression, a family concern, something that is a challenge for them. And we want you to walk away with the tools of how do we start these conversations. The last discussion was great in recognizing we don't have to be professionals to navigate these conversations. We just need to link them to the professionals who can carry that further, right? So when you sit with a student, we want to give you this acronym of feel, felt, found. How do I start to convey and communicate my concern for these students? First, you can say, I can feel how hard this has been for you, or I feel how miserable you may feel right now. Use that empathy we just learned about. I can feel how heavy this is for you right now. I felt this way before. Actually, in my own experience, I felt depressed and had a really hard time. Other students I've known, that I've taught, that I've mentored, that I've engaged with have felt this way as well. I know you're not alone in this, and I want to be able to help. And then lastly, found. I found that talking with somebody about this can be extremely helpful. I found in my own experience having support can be extremely helpful. We want to make sure that these students do not end up doing this alone. I think that's one of the biggest things. A recent study about suicide said that those who fared best were those that had a simple follow-up after they expressed a concern. Follow-up makes a world of difference. When you've had a bad day and someone texts and checks in and said, how was your day? Are you doing okay? That makes a world of difference. You were remembered, you were recognized, you were validated. If we follow up with the students that we care about in an email, a phone call, we pull them after class, hey, how are you doing? That makes a world of difference and can shift their trajectory. So we want you to know how to best have some of these conversations. For the sake of time, we're going to skip some role plays and some time to kind of digest a little bit of this, but I'd encourage you, even on your drive home today, think about how would I use this in my interactions with students, sharing how I feel, how I might have felt before, and what I found as helpful when I engage with students. Lastly, I want you all to pull out the UCC workbook, the bookmark in your folders. We heard about an amazing amount of systemic agencies and things like that support our students in the community, especially supporting their families as well. But what do we do when we have a student in our office on campus and we have a student that's in distress? I want you to walk them over to the counseling center. That's the first thing, is walk them over to us. We are open every day from 8 until noon and from 1 until 4:30. Please bring them over to us in that moment. We're not waiting. We want to just catch them where they are. Bring them over. We're in Magnolia Court next to the health center. We always have an urgent care counseling team on site and ready to support our students. Please walk them over to us. For those of you who are at regional centers, thank you for being here today. We're so excited you came. We also have a 24-hour support consultation and crisis line as well. You'll see that number here as well. It's our same main line, 626-815-2109. This, like the suicide prevention hotline, will also counsel students through their distress. Even better, it sends us a personalized report of that conversation, of the interventions provided, so we at the counseling center will directly follow up with those students, whether that's here on campus or within our graduate and professional students. So this is the number I really do want you to hold on to cater best and tailor our intervention towards our student body and our population. So thank you guys for your time. I want to make sure I also reiterate our learning objectives for today. So we hope that you walked away with a better understanding of the risks and suicide preventive factors associated with thoughts of suicide, substance abuse, and things like that. That you also understand and able to access the APU resources available as well. We talked about the care team and how to submit a care form. We talked about the University Counseling Center and also the Community Counseling Center and our availability there to serve students. We're also available for consultation for all faculty and staff. Please call us or walk over. If you want a tailored presentation for your office on how APU can intervene with the unique students you serve, we would be happy to do that. And lastly, that you see a better understanding of the resources available on campus. And so please take time after this to visit the tabling events outside. Please come and talk to any of the presenters after our time today. And would you join me in a big round of applause and thank you for all of our panelists who came today? Excellent job. Thank you all. Thank you, Sally. Thank you, Erin. And thank you all for your time.